Okay. As folks are rolling in, I would like to welcome you all to the 2021 UNC Water and Health Conference, and thank you for joining our session this afternoon or morning or evening, or wherever you are. My name is Drew Capone, and I'm part of the Water Institute here at UNC Chapel Hill, and I'll be your host today. So before we get started, I have a few announcements to make. If you are free and you'd like to join, please take advantage of the networking sessions this afternoon at 3:30 on the remote platform. So that's separate from the Pathable platform. And it's a good chance to connect with colleagues and some of the sponsors. Next. As well, if you've been attending the conference this week, I hope you've been paying attention because we'll be having a trivia night tonight at 3:30 on Remo for a friendly competition centered around this week's conference learnings. And the prize for winning that is a discounted registration. So if you're free, I highly suggest you go and participate. As we are not taking questions in the chat for this session. As with all the other sessions, we ask that if you have any questions for our wonderful presenters today, please do so on the Pathable platform. As you can see here, you have to go back to the Pathable website and please put your questions or comments in the chat. And of course, thank you to our sponsors. The sponsors specifically for this session are World Vision, USAID, Reckitt Global Hygiene Institute. So we appreciate their financial contribution to help us keep the UNC conference free and accessible to everyone. And I would like to just remind everyone that this session is being recorded so that we can share it with those who are not able to attend live. So now I would like to present our first presenter today, Christine Marie George from Johns Hopkins School of Public Health. So I'll let her share her slides and take it away.
Thank you, Drew. I appreciate the introduction. So my name is Christine Marie George, and I'm an associate professor at Johns Hopkins. And it's my pleasure to present on today the findings from our randomized control trial of the Shelby 7 Water Sanitation and Hygiene Mobile Health Program. And in particular, our results investigating the psychosocial factors influencing the effect of this intervention on hand washing with soap and stored drinking water quality. This study is a collaboration between my research group at Johns Hopkins and the International Center for Diarrheal Disease Research in Bangladesh, ICDDRB. And it's funded by a grant from USAID. And so the rationale behind our work is that when a diarrhea patient presents at a health facility, their household members are at a much higher risk of developing subsequent diarrheal diseases than the general population. And for cholera, for example, this risk is 100 times higher. And this is thought to be because household members of diarrhea patients are sharing the same contaminated environmental sources, such as drinking water, and also through person-to-person transmission through, for example, lack of hand washing with soap. Furthermore, studies have shown that the highest risk for household members of diarrhea patients is a 7-day period after the diarrhea patient is admitted to the health facilities. However, despite the growing evidence showing the high risk of the household members of diarrhea patients, there's very limited interventions for this population, and the focus is almost exclusively on the treatment of the diarrhea patients. And so this led our research group to the development of the cholera hospital-based intervention for 7 days. And the acronym for this intervention is CHOBI-7. And CHOBI means picture in Bangla for the pictorial wash module that's delivered as part of this intervention. And then the 7, again, is for the 7-day high risk period for the household members of diarrhea patients after the patient is admitted to the health facility. This intervention is health facility initiated. And so a health promoter delivers our wash pictorial module bedside to the diarrhea patient and their accompanying family members in a health facility setting. And the information that's provided focuses on hand washing with soap, water treatment, using chlorine tablets and boiling, and safe water storage. And these behavioral recommendations that are provided in the health facility setting are then reinforced through home visits during the 7-day high risk period. And so previously, we conducted a randomized control trial of this intervention between 2013 to 2014. And we found that delivery of the Shelby 7 program to the household members of cholera patients led to a significant reduction in cholera among this high-risk population. And furthermore, we observed that the intervention resulted in sustained improvements in hand washing with soap, as well as stored drinking water quality relative to E. coli 12 months post-intervention. And so these promising findings were shared with the Bangladesh Ministry of Health and Family Welfare, and they expressed an interest in scaling this program across the country. However, they asked us to broaden the scope of the intervention to include diarrhea patients of all etiologies, so not just focusing on cholera, to allow the intervention to serve millions more beneficiaries. And they asked us to develop scalable approaches for program delivery that did not involve home visits, since home visits would be a very challenging approach to take to scale across the country. And so this led us to our current work, which is the Shelby 7 Mobile Health Program. And mobile health presents a promising approach to deliver public health information in Bangladesh, given the high mobile phone coverage in the country. There were over 170 million mobile phone numbers registered in the government of Bangladesh National Phone Database. Furthermore, even in disadvantaged communities, we're observing high coverage of mobile phones. For example, our recent mobile health surveys in slum areas of Dhaka found that over 90% of households surveyed reported active mobile phone ownership. And in addition, the Ministry of Health and Family Welfare currently uses mobile health to deliver public health information. For example, you could receive a call from the Prime Minister encouraging you to take your child to get vaccinated or to go to the community clinic on Community Clinic Day. And so we developed the Shelby 7 mobile health program through 8 months of formative research, which included 60 in-depth interviews, as well as group discussions and a pilot study. And the formative research papers are listed at the bottom of this slide. And so for the Shelby 7 mobile health program, it is still a health facility initiated intervention where a promoter delivers our WASH pictorial module bedside to diarrhea patients, as well as a diarrhea prevention package, which includes a hand washing station, as you can see here on the left, developed by the ICD-DRB WASH group, as well as a water vessel with lid and tap and chlorine tablets for safe water treatment. And so upon discharge from the hospital, these households are then enrolled in our mobile health component, which involves receiving weekly voice and text messages from a doctor at a hospital, encouraging them to perform our key WASH behaviors. And to give you a sense of the cost of the mobile health component, to send weekly voice and text messages to someone's phone for 12 months in Bangladesh, it costs around $2 US using the VMO platform. So it's a very low cost approach for WASH program delivery. So we conducted a randomized control trial of the Shelby 7 mobile health program between 2016 to 2019. And this was conducted in Dhaka, Bangladesh, and focused on households living in slum areas. And we included 2 health facilities where we recruited diarrhea patients, Dhaka ICD-DRB Hospital and Mugda General Hospital. And patients were randomized based on the date that they came to the health facility and the ward that they were in. And so we had a total of 769 diarrhea patient households, and they were randomized to one of 3 arms. So the first arm was the standard arm, and this was the standard recommendation given in Bangladesh to diarrhea patients at discharge on the use of oral rehydration solution. We then had 2 mobile health arms. The first mobile health arm received health facility delivery of the intervention, plus weekly voice and text messages on WASH over a 12-month period and no home visits. And then our second mobile health arm received the same intervention plus 2 home visits. The findings from our randomized control trial were published in Clinical Infectious Diseases in 2020, last year. And we found that delivery of this intervention in both of our mHealth arms resulted in significantly higher hand washing with soap at food and stool related events, as well as significant improvements in stored drinking water quality relative to E. coli. Furthermore, we observed that this intervention significantly reduced diarrheal disease and stunting among young children. And so for today's presentation, we'll focus on understanding what the underlying mechanism of change was that led to the high efficacy of the Shelby 7 mobile health program. And in particular, what psychosocial factors were influencing our intervention. And so our intervention was informed by several health behavior theories. The main focus was the RANA's model, which is the risk, attitudes, norms, and self-regulation model. And we also, our findings were informed, or our intervention design and evaluation was informed by the integrated behavioral model for WASH, so IBM WASH. For our design, we included participants that were 12 years of age or older to receive our psychosocial factor questionnaire. Our questions were ordinal, and they ranged from 1 to 5, except for our diarrhea awareness question, which was a series of questions, a series of open-ended responses, and was coded between 0 and 10. The psychosocial factors we included were forgetting, response efficacy, self-efficacy, diarrhea knowledge, disgust, perceived susceptibility, instrumental attitudes, and DIRT reactivity. And so now I'll go into our findings. We included a total of 882 participants at our 12-month follow-up. So we administered a psychosocial factor questionnaire to these participants. And we found that delivery of the Shelby 7 mobile health program resulted in significantly higher diarrheal disease awareness at our 12-month follow-up, as well as significantly more response efficacy. So in terms of their belief that boiling their water would reduce their chances of getting diarrheal disease. In addition, the intervention led to significantly higher self-efficacy in terms of knowing that boiling the water, after boiling water, you could protect it from getting recontaminated, and also higher self-efficacy around being sure that you could wash your hands with soap before eating. And then finally, we observed that delivery of the Shelby 7 mobile health program resulted in significantly less forgetting. So in terms of remembering to wash your hands with soap before preparing a meal, which is a very important key time. And so now that we've seen the psychosocial factors that were significantly increased with delivery of our intervention, our next step was to conduct a mediation analysis to understand the underlying mechanism of change. And so to do this, we performed mediation models using the indirect macro. And we found that delivery of the Shelby 7 mobile health program was significantly, the high uptake we observed in terms of increasing hand washing with soap was mediated by self-efficacy. So sustained hand washing with soap at our 12-month follow-up was associated with self-efficacy. Next, we found that in addition, self-efficacy was a significant mediator of stored drinking water quality at our 12-month follow-up. We also found that response efficacy was a significant mediator of the sustained improvements in stored drinking water quality we observed at the 12-month follow-up, as well as diarrheal disease knowledge. And so to summarize our findings, we found that self-efficacy was a significant mediator of the Shelby 7 intervention's impact on sustained hand washing with soap practices at the 12-month follow-up. We also found that response efficacy, diarrhea knowledge, and self-efficacy were mediators of the intervention's impact on improved stored drinking water quality at the 12-month follow-up. And then importantly, we were able to use the findings from this analysis to inform the intervention that would be delivered as part of our scaling plan. So currently we're partnering with the government of Bangladesh to scale the Shelby 7 mobile health program across the country in government health facilities. And so we're able to incorporate the findings from the psychosocial factor analysis to further refine the Shelby 7 program for this population. So that concludes my presentation today. And I would like to thank our very large study team at ICDDRB for their support on this study, as well as our partners at the Bangladesh Ministry of Health and Family Welfare and my colleagues at Johns Hopkins. And so here I show a photo of our team at ICDDRB. And so this ends my presentation, and I would be happy to address any questions.
All right, thank you, Christine. So we have 5 minutes for questions, and it looks like we already have a couple of questions dropping in, but to give folks a little bit of time, I think my first question for you is, how do you recommend other WASH researchers determine psychosocial factors influencing WASH programs?
So that's a great question. And so it's really important that this is done from the beginning, to include as part of your evaluation psychosocial factors at baseline and then at follow-up to see how your intervention was influencing these psychosocial factors. And then conducting a mediation analysis is really the next step to understand which of these psychosocial factors that were increased actually influence the WASH behaviors observed as part of your intervention.
Great. We have a question from Scene White. Given that the messages came from a doctor character, she wants to know, did this create any confusion for recipients who thought they could talk to this person about healthcare issues, or was this mitigated in the way that it was designed?
Yeah, so we explained this from the beginning. And the doctor that we included was actually a doctor at the hospitals where we were recruiting patients. And so often they had already seen her in the hospital, but we explained that if they had questions about their health, that they should contact the health facility directly.
Okay, we have a question from Jenny Lamb. They ask, could you reflect, please, on the community's perspective? Was there a preference for household visits versus the mHealth program?
So that's really interesting. So this study was conducted before the COVID pandemic, and we had a combination. So some participants really liked the idea that we were able to have contact with them weekly, and that wouldn't be something that would have been possible with home visits. And some participants, they wanted more contact. So they wanted home visits to have more reinforcement. But it should be noted, as I mentioned earlier, even in the arm that just had health facility delivery of the intervention and then weekly voice and text messages for 12 months with no home visits, we saw significant sustained improvements in our WASH behaviors, as well as less diarrhea and stunting among young children.
And then we have a question from Gloria, who's asking, what psychosocial factors did you intend for the program to address? And then how does this compare to what was found in the mediation analysis?
So that's really important. So as I showed in the earlier slide, we targeted diarrhea knowledge, we targeted DIRT reactivity, self-efficacy, response efficacy, forgetting. And in our mediation analysis, we only found 3 key psychosocial factors, which were response efficacy, self-efficacy, and diarrhea knowledge. And so it showed that not all the psychosocial factors that we were targeting were actually significant mediators of our improved WASH behaviors.
Great. And then we have I think time for one last question here. Says, they love your work. Have your findings influenced the government of Bangladesh and others to use such approaches during the pandemic?
Yeah, so actually, when the COVID pandemic began, the government of Bangladesh reached out to us to see if we can share the content of our mobile messages. And they were already sending mobile messages as part of their programming, but we were able to share the Shelby 7 mHealth program messages with them. And so that helps to influence the development of their COVID-related messages. And something that I hadn't mentioned is that we use interactive voice response as part of our program. And so we would call people, ask them a question, and then they could press 1 or 2 in response. And we had a very positive feedback on that during our formative research. So that was a way to be able to engage beneficiaries in our WASH program, even though we weren't making in-person visits.
Great. All right. Well, thanks so much, Christine, for presenting and answering everyone's questions. It was a pleasure hearing about your work. Next, we're going to hear from Jeremy Lowe from North Carolina State University. So Jeremy, you have 10 minutes and I'll let you queue up your slides.
Thank you, Drew. So hi, everyone. Today I'm going to be talking about investigating poultry feces risk perceptions and management self-efficacy in rural Uganda. So overall, nearly 300,000 children under 5 died by causes related to WASH access in 2016. And since then, the safe management of animal feces has been identified as a potential strategy to interrupt transmission pathways of enteric pathogens. And when we consider animal fecal contamination, it's especially important to consider poultry, given how they are raised in a household setting and how they have been previously associated with infectious diseases in children. So we're really interested in understanding behaviors that can limit child exposure to poultry fecal contamination in a household environment. However, we don't have a good understanding of the best practices in managing poultry feces and the barriers that exist in adopting these practices. In the past, theoretical frameworks like the integrated behavioral model for water, sanitation, and hygiene, or IBM WASH, as Christine Marie-George just mentioned, have been developed to aid in the design of behavioral interventions in the WASH sector. And as part of these behavioral interventions, health risk perceptions particularly have been previously identified to influence WASH behaviors, and they again may prove insightful when managing poultry fecal contamination. So our study is really focused on characterizing the existing health risk perceptions and self-efficacy beliefs in rural Uganda, as well as understanding the relationship between these perceptions and poultry feces management behaviors. So data were collected in August 2021 as part of using a questionnaire and spot check observations as part of an inline evaluation following a trial of a poultry management training in the Masindi and Kirindogo districts of Uganda. Households were included in our study if they were part of a self-help group organized by the Water Trust, had a child under 5 at the time of the baseline survey, and currently owned poultry. So as part of this questionnaire, like I mentioned, we developed a module of poultry risk perception and management self-efficacy questions shown in Table 1. The 5 poultry feces management tasks we were focused on included keeping chickens in a designated area, washing hands with soap after handling chicken feces, cleaning up chicken feces in the home or compound, keeping children from touching chicken feces, and a negative control question that focused on washing clothes. The first question asked about how difficult the tasks were, and we included a follow-up question that asked what made a particular task difficult. The next set of questions asked about how confident the respondent was that they could always perform a task. Lastly, the final question asked about the perceived benefit of reducing diarrheal diseases in the children if they performed the task. Each of these constructs had a 5-point scale of answer choices. So for example, perceived difficulty, answer choices ranged from very difficult to very easy. So descriptive statistics and bivariate statistical tests were used to understand relationships between the risk perception and self-efficacy constructs and poultry feces management overall. These analyses were used to inform the development of a conceptual framework, which we situate in the existing IBM WASH framework. So I'm now going to dive into some of our findings. First, we'll look into perceived benefits in reducing diarrhea. When asked about the benefit of certain tasks in preventing diarrhea in their children, respondents gave an answer ranging from very unlikely to very likely on a 5-point scale. Each stacked bar graph here displays the proportions of responses for the 5 constructs on this scale. The percentages on the left-hand side in red represent the proportion of people who responded with somewhat or very unlikely, whereas the percentages on the right-hand side in green represents the proportion of people that responded with somewhat or very likely to prevent diarrhea. Also, descriptive statistics for each corresponding behavior are also displayed on the left-hand side. So overall, a majority of respondents across all these behaviors, about 85% believed each of these to likely prevent diarrhea, including our negative control question that focused on washing clothes. And when considering beliefs of self-efficacy in these 5 different tasks, we begin to see variability across the 5 behaviors. However, a majority of participants still were somewhat or very sure that they could always perform the 5 tasks. This is surprising though, because when we look at the descriptive statistics on the left that represent the corresponding behaviors, we see for the most part that they are not often practiced. And so now looking into perceived difficulty, tasks like washing hands after handling chicken feces, cleaning up chicken feces, keeping their children from touching chicken feces were mostly said to be easy, whereas 54% of participants said keeping poultry in a designated area was difficult. So based on these descriptive results, we see that perceived risk and self-efficacy may not always align. The perceived benefit of reducing diarrhea was seen to be consistent across all practices, with most participants believing the behaviors will prevent diarrhea. However, we begin to see variability when considering self-efficacy and difficulty of each of these behaviors, with corralling particularly being difficult. These differences between risk perceptions and self-efficacy could matter in understanding what behavioral factors ultimately influence a person's poultry management practices. So I'm now going to begin to make the connection between these perceptions and the actual behaviors. Figure 4 displays the perceived difficulty of corralling poultry with the actual self-reported use of a poultry-only enclosure. The bar on the left represents participants who did not report using a poultry enclosure, whereas the bar on the right represents participants who do report using enclosure. As shown, a higher proportion of people who report it was very difficult to keep poultry in a designated area do not use a poultry enclosure as compared to those who do use a poultry enclosure. This relationship was also found to be statistically significant. It is also important to note that when we asked the follow-up question about what made corralling difficult, 92% of respondents said it was either cost, time, or both. Across these groups, they both similarly report that keeping poultry in a designated area will prevent diarrhea. And this was not found to be, there's no significant relationship found between the use of enclosure and the perceived benefits of preventing diarrhea. So while many people believe that keeping poultry in a designated space would protect against diarrhea, there are barriers to doing so. Again, when asked about what made this practice difficult, 92% of respondents said it was either due to cost, time, or both of these factors. Because of this, it might be important to consider how cost and time are barriers, which may include looking into size of flock needed for people to believe enclosures are a worthy investment, or investigating other low-cost options for the containment and disposal of chicken feces. So now I'm going to dive into the hand washing after handling chicken feces. The two groups here represent people reporting hand washing after handling animals or animal feces. And here I'm comparing that to their self-efficacy that they could always wash their hands after handling chicken feces. The bar on the left represents the proportion of people who do not report hand washing at this key time, whereas the bar on the right represents people who do. We can see an unintuitive result. Of the people who do not report hand washing at this key time, a larger proportion of them said they were very sure that they could always wash their hands after handling chicken feces, as compared to people who do report hand washing at this key time. This relationship was also found to be significant. When considering the key hand washing times, the perceived benefit of hand washing after handling chicken feces to prevent diarrhea, we see a similar result. A greater proportion of participants who do not report hand washing at this key time also say that hand washing after handling chicken feces is very likely to prevent diarrhea. This again is a significant relationship. So overall, believing hand washing after handling chicken feces will prevent diarrhea does not always mean that people will wash their hands at key times. So we found these unintuitive relationships related to hand washing, and this really raises a lot of questions. Are people hand washing at this key time while still not believing it will prevent diarrhea? Are people believing that chicken feces are a lesser risk compared to other animal or human feces? And these questions really offer a point to dive deeper in the future. So taking these results into account, I want to situate our conceptual framework within IBM WASH. In Figure 8 here, IBM WASH displays the dimensions of behaviors being contextual, psychosocial, or technological, with these factors being spread across 5 levels ranging from societal to habitual. Our study is specifically focused on the individual level, which includes constructs like self-efficacy, knowledge, perceived threat, and perceived strengths and weaknesses of a product. And so in Figure 9 here, I present a conceptual framework of the behavioral factors that influence poultry feces management. Our risk perception and self-efficacy module in our questionnaire falls under the categories of psychosocial and technology factors. And just as a first pass, we looked at the bivariate relationships, but this framework can be used in the future alongside or with statistical models to understand predictors of poultry feces management alongside other social determinants like wealth, education, and wash access. So in the bottom right, I've also included a feedback form for this conceptual framework, and I welcome your input on it, given what I've presented today. And if you don't have time to scan it, don't worry, I'll revisit this slide at the end, and it's also available for download on the conference website. So wrapping up, I presented some hot off the press results featuring relationships between risk perceptions and self-efficacy and poultry feces management, which ultimately informed our conceptual framework. It's evident that these perceptions do not behave the same across all behaviors, which raises questions about the predictors of poultry feces management. In the future, it'd be helpful to continue to consider the role of these perceptions in influencing poultry feces management and what these perceptions may tell us about barriers that exist in adopting these practices. And so lastly, I just want to take a moment to thank the study participants, as well as Aisha Erjaman and Angela Harris at NC State, and Chris Pradas, Dali Apio, and the rest of the Water Trust team. Thank you.
All right. Thanks, Jeremy. You might have a record there, or close to a record, for collecting data in August and presenting it at the Water and Health Conference in the fall. So great job. And thank you for your presentation. As we have about 3 minutes for presentations, or about 4 minutes for presentation, or for questions, I mean. So as people are typing in the chat, my question for you is, thinking back to your results slide where you talked about the negative control question, how do you make sense of the results being similar to the other behaviors for your diarrhea question?
Right. So I think you're asking about the negative control question, right? And so, with this is kind of puzzling to us. And so I think this raises questions on we really need to consider like why it's so similar. And so this raises questions about the negative control that we use itself. And so with our module, where people becoming fatigued after answering all these questions, or just like simply the word washing and washing clothes hold a lot of weight to it. And so in the future, it'd just be helpful to kind of narrow in on a negative control question that can show the differences between these different behaviors. Yeah,
it's really interesting. And maybe just in general, people think they can do everything when everyone thinks they can do everything. That's very likely. So it's an interesting result, and I'm sure it's still, you obviously just collected this data and still need to think about these and continue to analyze it. But sounds like you guys are doing a great job. Okay. I don't see any other questions in the chat. In addition to chicken feces, are you guys thinking about other animals that might be a concern in this setting, and how would you apply like this approach to other animals in addition to chickens?
Yeah, that's a good question. So specifically, we were really focused on poultry because, like I mentioned, in this context of rural Uganda, they're often raised in this backyard setting, and so poultry are able to roam freely throughout the home or compound. It's a common practice to keep them in the home at night. But like I mentioned as well, I think it'd be really important to kind of expand this to understand, are there differences between poultry feces and other animal feces, and how people perceive the both of them? Because I think that offers a lot of interesting points to dive into for sure, and understanding best practices across both of them to manage it.
Okay. All right. Well, thank you for your presentation. I think that's all the time we have for questions, and best of luck as you continue working on this.
Thank you.
Up next, I'd like to invite Yolisa Nalule from LSHTM, London School of Hygiene and Tropical Medicine. If you want to cue up your slides, and feel free to take it away.
Okay. Okay. Can you hear me?
Yeah, you're good to go. You have 10 minutes.
Great. Thank you so much for the invitation. It's a pleasure to be here. So I am Yolisa Nalule, a researcher at the London School of Hygiene and Tropical Medicine. And it's my pleasure to kind of take you through a CHAMP study, the findings, which is a collaboration that the London School of Hygiene and Tropical Medicine did with WaterAid Cambodia, WaterAid Australia, and the National Institute of Public Health. So adequate hand hygiene practices throughout the continuum of care of maternal and newborn health are essential for infection prevention. In Cambodia, over 90% of all births take place in the healthcare facility. However, there are lots of wash gaps in these facilities, including low hand hygiene compliance that place both the mother and the newborn at continued risk of infection. The current hand hygiene improvement strategies are very limited. They're very highly medicalized and focus a lot on mainly improving knowledge and provision of infrastructure. And so innovative approaches informed by behavior science are needed in this field. So to this end, we conducted a 4-phased research study whose aim was to assess the feasibility of a novel multimodal healthcare facility-based behavior change intervention on hygiene practices around both maternal and newborn care in the healthcare facility and the home environment in Kampong Chhnang, Cambodia. It was a controlled before and after study, really proof of concept. We had 8 healthcare facilities, 4 that received the intervention and 4 controlled. These were purposely selected, and the intervention ran for 24 weeks. We looked at both the behavioral outcomes and process evaluation. However, we won't be covering the process evaluation in this presentation. So we started off with 2 phases of formative research where we found that maternal and neonatal care was conducted by a wide range of caregivers, even in the facility, across the entire care continuum. And this, not just the healthcare staff, but mothers, fathers, and extended caregivers, and all had low hand hygiene compliance. We also identified various psychosocial, physical, and contextual factors that were influencing these practices. So these formative findings then informed the development, design, and the field testing of candidate interventions using a participatory creative process, which was phase 3, creative phase. And following this, we enter phase 4, which is what I'm going to focus on, which was the implementation of the intervention and the testing. As you can see, it was done between March to December 2020, which coincided with the COVID lockdowns, which had some implications for our findings. So the formative research findings have been published for anyone interested. They're also part of the files in this session. So the intervention was delivered in 2 locations within the maternity ward. The first location was the labor and delivery room, and that was specifically aimed at improving hand hygiene practices of the birth attendants, so primarily the midwives during birth. And this intervention engaged the midwives in redesigning the delivery room. We incorporated cues and visual cues and reminders in very strategic places. We included social influence and accountability components such as pledging and wearing visible hand hygiene badges. And all these were implemented by the midwives during the participatory training, which took place in the delivery room, which is where care was provided. For the postnatal care ward, I'll be saying the PNC. These were targeted at improving all the caregivers, so not just the healthcare staff, but also the household members, and really focusing on hand hygiene during newborn care. And this was both in the PNC room and in the home environment following discharge from the facility. And the intervention visually demarcated the PNC as a clean hand zone by painting the entrances and the walls of the PNC bright green. We also installed a hand washing station at the PNC entrances and alcohol-based hand rub at the end of each bed of the PNC, as you can see here and across the various healthcare facilities. And then we also gave the mother her own personal alcohol-based hand rub and kind of strategically placed a number of nature-evoking cues and messagings to guide, remind, and reinforce adequate practice. One of them was directly on the newborn baby, which was strategically placed with kind of a hand hygiene messaging on the hat. So the women were recruited upon admission to the facility during stage 1 labor and were observed at 3 time periods: 6 hours during the labor delivery, 4 hours in the postnatal care ward, and 6 hours at home following discharge. And I'll split the presentation of the results by the environment. So we did structured observations, and in addition to these, we also did semi-structured wash surveys, which were conducted to determine the wash conditions at the facility and the household level. So I'll start with the childbirth environment, which was targeting just the midwives. So a total of 99 women were observed, slightly more observations at endline than baseline in both groups. However, the mothers were similar across both groups by age and previous live births. And for this particular analysis, when I say adequate hand hygiene, we define it as hands, the birth attendant washed their hands with soap and clean gloves were worn, and they avoided any potential recontamination of their clean hands and gloves. And so basically we calculated the proportion of the key hand hygiene opportunities that were initiated under adequate hand hygiene for each birth attendant. And the hand hygiene opportunities we looked at was basically what was the birth attendant's hand hygiene prior to doing a vaginal examination during labor, prior to the start of delivery, so when the cervix was fully dilated, and prior to immediate newborn care, so when the cord was cut and the baby was still in the labor and delivery room. We also looked at maintenance of adequate hand hygiene, although again, that's not going to be covered, but whether the birth attendants who had adequate hand hygiene at the beginning were able to maintain this hand hygiene until the end, or if someone didn't start off under adequate hand hygiene, if they self-corrected in the middle of the procedures. So these are our results. If we look at kind of the percentage point difference, we can see that anywhere where there's a plus is where the proportion of opportunities that were initiated under adequate hand hygiene increased within the same group from baseline to endline. And we can see this increase happened in our intervention groups, and the reverse happened in the control groups. However, to calculate the intervention effect, we conducted a difference in difference analysis. And so the last 2 columns show the output from logistic regression models that we run. And so what do we see here? So when we look at our combined category, so this is basically just adding labor, delivery, and newborn aftercare, we can see that the adjusted odds of practicing adequate hand hygiene prior to any of the hand hygiene opportunities was almost 5 times greater in the intervention group compared to the control. When we look at the individual, categories, we see that the adjusted odds of initiating a vaginal examination during labor was 7 times greater in our intervention group compared to the control group, and almost 10 times greater prior to immediate newborn care. There was no evidence of a difference in the odds of birth attendants initiating the delivery under adequate hand hygiene between the intervention and control group. So moving quickly to the postnatal care, this is still within the facility. The definition changes to just hands washed with soap or rubbed with alcohol-based hand rub. And the hand hygiene opportunities that we looked at was prior to holding the baby, prior to cord care, and prior to cleaning the baby's bottom following defecation. And basically what we see here is, this is the breakdown of adequate hand hygiene practices during newborn care of all the caregivers, and also split by her caregiver group. And we're only looking at endline because in our baseline, adequate hand hygiene was 0% across. And so what we see here was there was a higher proportion of adequate hand hygiene practiced in the intervention group. However, you can see that even in the intervention group, it was low, less than 10%. And so with the intervention effect, after adjusting for shift time, facility type, and professional qualifications, caregivers in the intervention group had 9 times the odds of practicing adequate hand hygiene during newborn care in the postnatal facility compared to those in the control group. And just moving quickly to the home, I realize I'm slightly over time. Moving to the home environment, this was just looking at the household members. here, the home observations were only conducted among the participants who gave birth at the primary healthcare centers. So that reduced number from 99 women to 44, which kind of also which explains the number of observations, but also because of the COVID kind of guidelines and restrictions, we're only able to have 1 hour observations at home during endline compared to the 6 hour observations at baseline, giving us a very limited number of observations. And so we did not proceed to test effect in the home environment, given these very low participant numbers and limited number of observations. So in summary, our results do suggest the potential of facility-based multimodal behavior change intervention to improve hand hygiene practices that are critical to maternal and neonatal infection along the continuum of care. We noticed improved hand hygiene practices around maternal care during childbirth, newborn care during immediate and early postnatal care in the facility, but we can't say anything about the home environment as we had no analyzed intervention effect. Thank you.
Okay, thank you so much for your presentation. It was very interesting. So we have a couple minutes left for questions. See, we already have one here in the chat. Joff is asking, be very interested to know if you have any ideas why hygiene behavior decreased in the control groups, even in the light of COVID during the study.
Yeah, so this we did find that really interesting. That yeah, we saw kind of this decrease, and you know we're doing kind of a process evaluation and trying to kind of understand what really happened, because yeah, that was a very huge. We expected the opposite, given that it was COVID-19 that we were going to see quite a high an increase in the in both intervention and control, but this didn't happen.
Yeah, interesting. There's another question here from Lindsay. So they mentioned for the most part, a lot of your results, adequate hand hygiene was still under 20%, and for some of those was like below 10%, which is still quite a ways from where an ideal range would be. So given that you guys are using a multimodal approach and all the kind of a robust intervention, do you have any ideas what barriers still exist in this setting to hand washing?
Yes, so I didn't present the process evaluation, but we have kind of we are on par to that. But one of the really huge barriers was actually gloving habits. There is still a lot of kind of wearing gloves without kind of intermediate hand washing. So actually a lot of the hand washing practice, that's where it was. It wasn't really that they were not washing hands at all. It was because there's this a very strong gloving norm where they double glove or they was triple gloving, and that we didn't kind of reach that. We're not able to address that with our intervention. And a lot of the gloving norms or the gloving habits in our study from our formative research is really due to institutional factors. The midwives are very overwhelmed. Half the times it's just one midwife doing the entire birth. And so there really is no time. There are human resource shortages and time. And again, as much as we kind of tried to do some restructuring of the environment, making the hand washing station closer, there are just some kind of factors that we were not really able to address with this intervention, such as addressing things like increasing staff with such kind of a very hectic time as childbirth is.
Yeah, it's understandable. All right, well, I think that's all the time we have for questions. So thank you so much for your presentation. If there's anyone else who has questions, please put them in the chat, and I'm sure all of our speakers would love to respond to you there. Or you can reach out through the Pathable platform and send a direct message to any of our speakers today, and I'm sure they would love to talk to you about their work. So, all right, enjoy the rest of your day, and I hope you can join some more of the sessions today and Enjoy the rest of the conference.
Thank you.